You brought up this contrast between a type 1 FLT3 inhibitor like gilteritinib that hits both the ITD and the TKD, and quizartinib, a type 2, just the ITD. Does that matter in terms of mechanisms of resistance? What are we seeing in terms of resistance to these drugs? Does the TKD matter? And is that how we should choose?
Well, I think it does matter for two reasons. There's also a difference between having a TKD only and having a TKD on the background of an ITD, particularly if you've had prior exposure to a FLT3 inhibitor and then that shows up. If that shows up on the TKD shows up on the background of a FLT3 ITD, those patients across the board don't respond to drugs like quizartinib or sorafenib. The TKD only, we don't know how driven that is by FLT3. It may be present, but not a major driver. There's some controversy on this. I know we've talked about, are there patients with TKD where it is a driver mutation, perhaps in a high allele burden in that setting, where they're going to respond to a drug. And we have seen responses to gilteritinib in that setting.
But not in the label.
It's not on the label. It's not something you can readily get in any lab. You'd have to do an assay to say that. So we really are left with a yes-no question there. So again, if you have both mutations, I think that's an indication that you really favor using a type 1 inhibitor. If you had one or the other, then we got to look at the drugs and see what's better.
But the simple truth is, in the relapse refractory setting, a single agent might give you a response. It's not going to give you a response for very long.
Right.
Gilteritinib is a great drug and inhibits both types of mutations, and then you're just going to get a RAS mutation that's going to make you resistant. We've got to combine them and move them up earlier.
Yeah, but with the TKD, I think that was something that we were a little surprised because I reviewed the initial Lancet Oncology data that we don't see clinically much, and it's rare, it's 5% of all patients. But a single agent TKD, you had 12 and then 12, and it's like 1 or 2 responders. So I don't know, do we think crenolinib or midostaurin are going to be more active? Do we have data for that, or we just don't have anything that hits TKD alone?
Well, we do have drugs that hit TKD alone. I think my impression is you have to have a high allelic ratio. It's got to be a driver for that patient. And even then, the response rate is clearly lower than the ITD.
And that's probably the most important observation on the subset analyses from the ratified trial, that the hazard ratio for survival was actually greatest in the TKD population, making you wonder.
Very interesting.
I mean, is it really FLT3 that we're inhibiting? Before we leave this topic of FLT3 inhibitors, I just want to touch on one thing. Would one of you like to comment on FLT3 in combination inhibitors in combination with less intensive therapy, like gilteritinib with azacitidine?
Well, in fact, the MD Anderson headline.
Well, not with gilteritinib though, but we haven't done. But with azacitidine, which Jorge and some of our fellows presented last year, we saw the response rate. Now these were frontline and relapse FLT3 ITD mutated, and azacitidine in the frontline setting actually gave us, it was 82%, small numbers, about 21 patients, and the survival was actually 21 months. So these are the aza-venetoclax group patients, not fit, induction. So I think that's really exciting. We're continuing to enroll HMA. Quizartinib, I know there's an HMA gilteritinib, and this could be very potent. And of course, we may or may not get to this, but can you add venetoclax? So you have to dose reduce, interrupt, but you may really get a blockbuster.
But not using chemotherapy. Chemotherapy, if I give you chemotherapy, Harry, I'm afraid I'd do two things. I'd make you very upset and your hair would fall out.
We're not friends
anymore. But in addition, FLT3 ligand would rocket up in you a few weeks later. That ligand is a cytokine. It's like GCSF. The body's trying to regenerate your bone marrow. It directly impedes these FLT3 inhibitors. So you don't see that effect when you combine it with the low-intensity agents. And so again, this perhaps is the origin of my bias for backing away from these intensive chemos and going less intense.
Very interesting.